So how about specific foods? And I can recommend two very good books that are in the bookshops now that give good insights into this area. One from a scientist who survived cancer and how he brings food into his dealing with cancer as a chronic illness, and the other is a lot of science to do with this area. And what the angles to all of this are foods that can block angiogenesis, foods that can influence the seed and soil, foods that can block estrogens, our own estrogens, but also the estrogens, plant estrogens and chemical estrogens that may be very relevant. Foods that promote the cancer being able to die or commit suicide, this is called apoptosis, and foods that can support the immune system or detoxify chemicals or things that are bad for us. These foods are generally called nutraceuticals. Obviously I cannot go into all of these, but these would be the classic ones, and the chemicals like curcumin and resveratrol and all those chemicals have been studied in laboratory models and in experimental models by and large. And these are phytochemicals, in other words plant chemicals, and the most active ones are these polyphenols. So just a few. My favorite is green tea. I like green tea. 20% of the world intake of tea is green tea, 80% is black tea. The good stuff in green tea are catechins, that is fermented out of black tea. And why I like green tea is that I, as a clinician scientist, would give my right arm to have published in Nature. So this is really serious science. And there are some studies that show that angiogenesis, central to oncogenesis, is inhibited by drinking green tea in experimental models. For example, this is a mouse cornea, and you inject VEGF to the cornea, and that stimulates new blood vessel formation. Mice fed green tea, it's inhibited. Interesting. Hippocrates called cabbage the vegetable of 1,000 virtues, and my mother would be very surprised if she were alive today that I can come up with one virtue for cabbage, but it is the prototype of the cruciferous vegetables. The star amongst all of, and these are the isothiocyanate is what you get when you digest cruciferous vegetables, and probably the star of that is sulforaphane, which is in all of them, but is predominantly in broccoli. And this has been shown to be particularly effective in the laboratory animals and prevented certain cancers, and has been shown to have some inhibitory effects, but in particular on stomach cancer. The albumin, garlic has been used as medicinal therapy for generations, as you know. And again, the specific effects of garlic and its breakdown products and that family relate to these end products, which again have protective effects against stomach cancer in many models. A very interesting family of foods are the soya-based foods, and there's a ton of them, and you know probably more about these than I do, but the interesting thing about them is that some of them have structures, in particular genistein, which is similar to our estrogens and androgens and can have an effect a little bit like tamoxifen. Okay, and there are some studies, epidemiological studies, that from Japan in particular, where soya is part of the staple diet, that the incidence of breast cancer, for example, is extremely low, and even remains low where women emigrate, having been brought up on soya. So it's food for thought. Turmeric is very interesting as well. Curcumin in particular, which is again staple in India. The incidence of lots of cancers is very, very low in India compared to the USA, and which is suggestive, although no proof. But the interesting thing about curcumin is that it has very strong antiogenic properties, and it does inhibit that key transcription factor, NF-kappa B. And finally, red wine or resveratrol has been shown to not only inhibit the growth of certain cancers in animal models, but also to impact on survival genes such as sirtuin, which is a gene supposedly important for longevity. Finally, in this section, how about fat? And this is the big topic of interest that's overdone, I think. And the death rates, for example, for many cancers plotted against the fat per capita in the population shows that societies that eat a lot of fat have higher incidence of cancers, particularly a lot of the hormone-related cancers such as breast cancer. And the discussion has really moved not so much to relation to the quantity of fat, but to the quality of fat. Americans are eating less fat than they've done in the past, but the obesity rates are still going up. So the quality of fat, the good fat being the omega-3 fatty acids, the bad fats being omega-6, but also trans fats and industrialized fats. So that's where the science is at the moment. And secondly, and hugely important in this area, how animals are bred, how farming is done, and how that brings fat into our world is also a very important dimension to the fat story. In terms of the science, most of the science, epidemiological science, relates to relative risks. So the hypothesis is there's no association between the two, which is a relative risk of 1. And if the studies show that for cancer patients they had more meat or vegetables or less meat, the relative risk is rated on that basis. And this is what's shown. For colorectal cancer, the relative risk overall is about a 30% increase for red meat and colorectal cancer, or for processed meat and colorectal cancer. And for fruit and vegetables in colorectal cancer, the relative risk is less for those that have a high intake of fruit and vegetables. Intervention studies are extremely difficult, and this is a lesson and a salient message from major intervention studies in Finland and the United States that involved maybe 80,000 patients who, based on the fact that lung cancer patients were shown by Sir Richard Dahl many years ago to have lower levels of carotene in the blood, they were given extra carotene, extra vitamin A or extra vitamin E. This study in particular showed that those patients with the extra amounts of these factors had a higher mortality rate from lung cancer. So everything is not as it seems when put to the test, and there are some difficulties in these interventional studies. And a huge women's health initiative study of almost 50,000 women given lots of less red meat, less red meat, fruit and vegetables and so on, show that the risks of colon cancer and breast cancer was no difference between those who just had a normal diet. So there's sometimes a disconnect between the laboratory and experimental data and what is shown in very difficult to perform interventional studies. Finally and briefly, obesity and the metabolic syndrome is all around us. We are witness every day to the obesogenic environment that we live in, and I'm not here to preach about this because I think this audience is converted to the problems that exist in our society. But it is important to point out that the basis for this association of increased incidence, but particularly the increased mortality, is an enormous study that was undertaken and published in the New England Journal of Medicine recently of 1 million adults followed for 16 years. And what it shows is that the bottom line really was that 14% of all deaths from cancer in men and 20% in women may relate to obesity. Particularly evidence for the ones I said, esophageal, pancreas, postmenopausal breast, uterine and kidney. And in this area, myself and Tom Walsh here, we're esophageal surgeons and we look after this, but it's a fact of life that more and more patients who have esophageal adenocarcinoma now are overweight or obese. And it's an interesting disease model. I'm just going to digress very briefly to show you some science, if you like, in action. Many of you are GPs. Reflux is all around us. 40% of the population have significant reflux. The model for esophageal adenocarcinoma is acid reflux, a change in the lining to what's called Barrett's esophagus, which is a marker of risk, but which is an adaptive inflammatory condition. And a certain percent of these patients then go on to develop a very difficult cancer to treat. We've done lots of research work in this area, but I just want to highlight a paper we published last year of a prospective cohort of patients well over 100. And of this, 78% of patients with this condition called Barrett's esophagus had central obesity. 46%, we would have expected about 20%, had the metabolic syndrome. And intriguingly, those that had most Barrett's esophagus, the longer segment of esophagus damaged by the acid and more at risk of cancer, a higher percentage of those had metabolic syndrome, suggesting in practice how inflammation and cancer can tie in with obesity and metabolic syndrome. Encouragingly, a big study last year showed that the treatment of obesity, and this would be radical, but some patients obviously have anti-obesity surgery performed, very, very common now in the United States and increasingly common here. But encouragingly, comparing a population of patients who had morbid obesity surgery with control patients who did not, the incidence of cancers for women was markedly less for men but not significantly so, and this seemed to apply to the well-defined obesity-related cancers but also to the not well-defined obesity-related cancers. So definitely, again, food for thought and for consideration in the whole debate. So in conclusion, ladies and gentlemen, not everything we do is an exact science or based on a randomized clinical trial. I think there's enough science out there in this whole area of food and cancer and evidence every day in what we see around us and in the data in relation to obesity and cancer to take this very seriously. And nature has nurtured, if you like, certain foods with their genes and their uses essentially since the beginning of time, and we should pay some heed and respect to that, although it is difficult applying this into clinical research studies. What is accepted, and this is from the American Institute of Cancer Research, is that obesity is strongly associated with a number of different cancers. Proof. What is accepted is that red meat and processed meats are convincingly associated with colon cancer. And what is probable in terms of decreasing risks are fruits and vegetables, green tea, garlics, tomatoes, all these sorts of things that we touched on. Probable, but difficult to do the slam dunk research to prove that. But what is extraordinary, if you look at this from the same organizations, is the percentage of all these cancers that they feel there is sufficient data on to ascribe nutrition as being key to their cause and key to their prevention. I should be on a commission from Waterstones here, but the final book I'd like to promote is a fantastic book from Deborah Davis. It's in the bookshops, and she is the professor of environmental oncology at Pittsburgh. And she's fought the administration, if you like, over many years in the United States, particularly to do with tobacco and chemicals. But the reality is that in 1950 was the first complete proof that smoking causes lung cancer. And we're still debating and trying to enforce that now. Obesity and nutrition, there's less linear, the link between the problem and cancer. But we do need to educate our communities, healthcare workers, and the public, and obviously engage with whoever needs to be engaged with, who may not like change in this regard, and do that as a matter of urgency if we truly are at the crossroads. So again, thank you very, very much for the opportunity to talk about this topic.